pain with a lot of SI joint movement. So if you think about setting somebody up for this test, you're going to get in the Thomas test position, kind of like you're looking for hip flexor length. You want their legs hanging over the edge of the table. You're going to have the leg that you're not testing pulled up to at least 90 degrees to where it's kind of in a slack resting position, and you want to put the painful side down. You're going to apply a overpressure to the painful side while blocking the non-painful side, because what you're trying to do is torque the pelvis or torque the SI joint to see if there's any pain elicited with in-range movement with the SI joint. If you have, irritation, acute irritation to the dorsal SI ligaments, which is probably one of the more common presentations that you'll see in SI joint. Charlie talked about the posterior longitudinal ligament on the SI joint being a really big pain provocator. This is a test that might elicit some of that pain for those people. Can I have a volunteer to show what this test looks like?
This one might get me.
Do you have pain?
On this left side.
All right. So you know the Thomas test position, so kind of get into the Thomas test position. So without ripping his pants, here's what I'm going to try to do. You want him to kind of get in this comfortable position, let this leg hang. You want to apply an overpressure to help him with this. One of the big things for doing that, the reason that this leg is up and that you're going to apply a counter pressure, is to make sure that you don't get a lot of anterior pelvic rotation overall, which again is going to jam them into lumbar spine extension, which could give you a false answer. Or a false positive. You're going to look for recreation of their pain. So if they say, oh, yeah, that hurts, and you say, well, where? Well, you're stretching the crap out of my hip flexor. Well, be specific to recreating their pain. So I'm going to give him some pressure here. Now I'm going to slowly go into overpressure on that bottom leg to see if we recreate any of the pain that he's used to feeling. So I was very easily applying that force in. I'm not just going to jump on him and crank his leg down. What did you feel with that, Matt?
Towards the very end, I started to feel that reproduction.
Right. So we're most of the time the SI joint, a lot of the times the painful tissue is actually the overlying ligamentous tissue, like Charlie pointed out. Maybe it's not actually the joint surfaces themselves. So if you think about tissue hysteresis and the principles of Cretos, it's going to take a little while for that ligament to actually feel those forces, or maybe it slowly starts to extend, or the joint is actually allowed to move further due to the tissue hysteresis effect. So you can actually get a better test if you hold that for a little bit of time and slowly apply it. So then we would test the other side. Normally when you're testing, you also want to test non-painful side first, so the patient has a reference to know what you're going to do. They're going to guard less on the other side. Plus, it's just best practice to test both sides and the non-painful side first. And he's got no pain there. So if he had pain with Gainsland's, we'd also want to go in and test out some of the other tests, right? Because any one test in isolation is really poor for diagnostic validity. But we've got to group these tests together, and that's going to make us feel more strongly about our conclusions. So if we're going to test him for the Patrick's or Faber's test, also called the Figure 4 test. Have him slide up on the table a little bit. So we'll go non-painful side first on this. Really simple, easy test. This is a good hip clearing test, but it's also an SI test. Go up, leg, heel above the knee, kind of in this resting position. Don't put it right on their kneecap, because that can be pretty uncomfortable for some people. Some people have really poor mobility, so you might have to help them hold it right here for a second. Then you're going to block the opposite ASIS and then apply it downward pressure. See if they feel stretch, see if they feel pain. You could say, oh man, this really hurts. Where does it hurt, Matt? Does it hurt? So yeah, he feels big stretch in his adductors, maybe a little bit of pressure in anterior groin. This is why this is a good hip clearing test as well, just for general hip pathology. You're looking in this scenario though, for it to recreate his SI joint pain, his forearm finger area pain, kind of right in this little circle. If it doesn't recreate that, then you've got a negative test, regardless of if he says it's stretch or pain in the front of his groin. Some people will also have problems with the knee in this, so you definitely want to be careful. Let their leg fall slowly into it. He's actually got more motion on this side. Start to recreate pain. Left SI area?
Yeah.
All right, so we've got a positive test again. So we got 2 positive tests so far. So we're kind of leaning toward, hey, maybe we should continue to test the SI joint and move away from the lumbar spine. That's one of the things that you were thinking, you know, if you're going in from your subjective evaluation and he has pain in his low back area, well, is this visceral pain? Is this lumbar spine pain? Is this SI joint pain? Is this glute pain? Is this sciatic pain? So you're kind of whittling down, or figuring out, well, this seems less likely to be lumbar pain or less likely to be glute pain and more likely to be SI joint pain at this point. So you're going to continue to test things out. Another test would be the sideline hip abduction test, which is essentially a gluteus medius manual muscle test, but you're not looking for weakness. You're looking for recreation of pain in the area that he's used to having pain. So you want to go painful side up on this test. So I usually help people similar to like you're setting up for an over test. You guys, have y'all got to that yet? IT bandling test? Okay, never mind. Forget what I said. Kind of help him get to about 30 degrees of hip extension, or a little bit of hip extension, about 30 degrees of abduction. Have him hold right there. Then you're going to slowly apply an overpressure and see if it recreates any pain in his SI joint area.
You did that when you first started.
So he felt a little jolt of pain and then kind of went away. All right. So that would be, again, a positive test. And then,
For someone who doesn't have enough knee flexion to do the favorite test, how would you do it?
so it might not be your best test at that point. Sometimes due to patient's anatomy, you know, they can't get into the positions that you need them to. So it doesn't always work perfectly like that. So say somebody had a knee replacement and it just kills them, or they don't have enough knee flexion to get into this position, because it will happen sometimes. You got to do the best you can. Sometimes you'll kind of hold right there. I've even put my body on top of somebody's knee while I hold their ASIS and try to hold their leg in as much knee flexion as possible. Kind of got to get ingenuitive with some patients sometimes, but right now don't worry about that. You'll learn that when you get out in clinic. Any questions?
Do you ever, I know this is probably the more correct way to do it, but when I was on my clinical, sometimes they would just, if they thought it was SI, they would just do like a muscle energy technique and see if it reduced their pain, and then if it did, they would just go ahead and say
So
SI.
I call that throwing crap against the wall and see what sticks. Because it's a really good treatment, but if you don't know what the cause of the pain is, you could be jumping the gun, right? Muscle energy techniques work extremely well, and one of the reasons that they work extremely well is because they're prolonged held isometric contractions. If you follow some of the recent research, isometric contractions are really, really good at decreasing pain. So you can get a false positive there if you get a muscle energy on somebody without determining what the cause of pain is. You could reduce their pain, at least transiently, but then you're chasing a rabbit down the wrong hole as far as trying to treat them. That would be my opinion. Dr. Holmes might get a different opinion, because
I have a completely different opinion, but his is the prevailing opinion probably. I would say that the treatment is part of the evaluation with muscle energy technique, and to see whether symmetry occurs and if it occurs.
I would agree with that, but you haven't tested out to figure out what maybe the underlying pathology is. Dr. Holmes would already figured out, he feels like he's got some sort of a pelvic malpositioning or sacral malpositioning by doing some of the other tests. If he would do his MET as a test to see if it reduces pain, and if it does, then it's
Actually,
his treatment.
I do it for symmetry to see if it changes the symmetry.
You gotta be careful of though too is there's tons of opinions out there. So one problem that we have in outpatient physical therapy right now is that you hear something in school and it's gospel and verse, and then you get to the clinic and the clinician's now a bad clinician because what you heard from the sage on the stage, and not calling you out here, just saying that it should be either one of y'all. Either one of y'all could could be construed as the source. Okay, evidence is coming out every day that refutes what you're hearing today, and it's a little different than what I heard in MSK class 14 years ago. So keep that in the back of your mind. Just because a clinician's doing something, if they have a solid rationale for how they do it, they reproduce that over time, they're able to provide you with that clinical rationale, not just the because I said so, and they get results, they may be doing it totally fine. It's just their way of doing it based off of the way they were taught or the way they've evolved. So just keep that in the back of your minds as you hear from all of us and our different views and biases and things like that, that it's an N of 1.
That's why you have to hear, this whole course is a survey course. And you have to hear multiple things, because you're gonna go out there and your CI